You guys are done with farm, right? Okay, on to neuro next. So we're going to go just into the kept on learning, talking about the posterior pituitary and some of the Endo 101 type topics. And again, these will all be posted at the end in one giant PowerPoint. If you guys want me to post them after they're brief, I can do that too. Let me know. And they will just be individual, like block 2, lesson 2, lesson 3 if you want. Okay, first question. Which of the following is an example of a small lipid-soluble hormone that can pass through a cellular membrane? So remember, those lipid-soluble hormones are those thyroines and steroids, okay? And that will help you. Which one are you thinking? Here in E? Anybody else? Anyone else agree with E? Anyone else think of something else? Right, so I said thyroid and steroids. Yeah, good job. E. Great, so in case you forgot. I would tell you, I would give you a little bit more if I did a question like that. All right, which of the following explains how the majority of endocrine systems function? So we have high levels of circulating hormone increases the synthesis and secretion. Low levels do the opposite. C or D, I have no idea. C, yes, C. This is the foundations of endo, right? The negative feedback loop. So if I have high levels of said hormone circulating, my endocrine system is going to react by decreasing synthesis and secretion. Good job. If you're on D, practice, use the charts. Teach your dog, teach me, and then I'll feel better. And you'll feel better about it. All right. Which of the following describes an endocrine hypofunction within the pituitary? So hypofunction within the pituitary. Something's going on causing less hormone production. Primary, secondary, resistant, or ectopic? Here's some primaries. Anyone for ectopic? Anyone for resistant? Remember resistance we talked about with DI, and then secondary. Secondary. So remember, the problem is in the pituitary. So whether it's secondary hyperfunction or secondary hypofunction, alteration in the pituitary or the hypothalamus is secondary. So with primary, if it's a thyroid issue, where would it be? The thyroid, right? If it was like adrenal gland and it was related to cortisol, primary would be in the adrenal gland, right? Any pituitary thing is secondary. Resistance is the endocrine function is working well, the negative feedback loop is working right, but regardless of how much hormone is in the blood, it can't get to do what it needs to because there's resistance at the site. And then ectopic is what? Something outside the endocrine system that's producing excess hormone. It's like maybe a cancer or something. Okay. Feel good about that now? Maybe? You won't miss it again. Maybe a different question, but potentially the same idea. Which of the following lab values would be expected in a patient with a syndrome with SIADH, syndrome of inappropriate antidiuretic hormone? SIADH, you have to think is ADH high or low. Inappropriate ADH. Any guesses in one grade? E. Perfect. Okay, so why E? Let's do this one together because this is a disease one, so we'll do it together. So first, with SIADH, going back to this, what does sodium, what changes in sodium in SIADH? Does it stay the same, high or low? It goes low, right? Because there's inappropriate ADH secretion. So ADH goes high, we retain all of the water, and so the serum sodium level decreases, right? And water overload. So just knowing that, we got it down to B or E. And then we lean on the specific gravity. Does that make sense why it's higher in specific gravity, right? Because it's super, super concentrated because we're soaking up all that urine, or excuse me, soaking up all that water, decreasing urine, and the urine that comes out is super concentrated. Okay? All right, and there's the slide. Don't just memorize it though, you can problem solve it. Okay, switching. Now lab values for a conscious patient presenting with diabetes insipidus. So you have to think, is ADH too much or too little ADH? One needs to be. After last one, I heard some right E's. I heard some E's. I heard a D. Perfect. Okay, C. You guys might have said C, and I'm just old and you can't hear. But okay, let's talk about it together. So here's the question. Urine. Okay, let's start with the urine this time. Specific gravity. In diabetes insipidus, they have a large voluminous clear water. So what's our specific gravity? Low, right? Sweet. So we're down to 3. A, B, C, or D. Or sorry, A, B, C. So then this person is conscious. So they're drinking a lot of water, and the goal with that is to stay hydrated and to get homeostasis with their thirst. So would they be hyponatremic? Would they be low? No, that would be the opposite. That's SIADH, right? Hyperkalemia, we didn't talk about that correlation, but normotremia because they're conscious and they're. But I did tell you on the test, I'm not going to throw sodium levels at you with diabetes insipidus because it varies so much on if they're drinking enough water. Unless they're unconscious, right? So if they're unconscious, what happens? They're going to be hypernatremic because that thirst center is gone. Make sense? Maybe? Okay, all right. That's it for posterior pituitary. We're going to talk all about anterior pituitary. Any questions before you get going? No. Okay. These are our diseases we're going to talk about. 3 adenomas. And then what happens with deficiencies. So we're going to be at excess at the beginning and deficiencies towards the end. We'll get to what we can. It is 3 o'clock on Monday plus it. But you guys are, you set my expectations really high. You're all awake. Last Thursday, last Thursday, but I realized you had farm to go over your whole weekend and your morning. So we'll see how far we get today. I am much more a morning person too, so I'll do my best. Okay, so hypothalamic pituitary axis. So this is just to review, you guys know this already. The hypothalamus you think of as kind of like the control center for the endocrine system, right? And located there, you can see on the diagram right above. And it regulates the pituitary gland with its releasing and inhibiting hormones. But what we're really going to focus on in this class is the role of the anterior pituitary. It's a true gland. It has a blood supply, and it actually synthesizes hormones. And I added this. It's not very big. How crazy is that? 5 to 7 millimeters in height, 10 millimeters in width. This little thing tucked away in your sella turcica is involved in so many things. Body's pretty cool. It makes up 80% of the whole pituitary gland, and which makes sense as we're going to talk about it over the next multiple days. And it regulates growth, development, sexual development, fertility, and lots of things. And then just fun facts, so it doubles in size during pregnancy, and then as we get older, it shrinks. So how can I use that information to implant? So for pregnant people, what do you think, if they're deficient, they have thyroid disease, hypothyroidism, you think they're probably going to need more hormones when they're pregnant? Yeah, right? It's bigger. And what about our elderly? So the lab ranges I have for you guys, do you think they might change a little bit when they're older? Yeah, because it naturally, we need less hormones. We need less testosterone typically when we age. Good luck telling them you're a 60-year-old man that, but again, that's what we do. Which for sure for thyroid, the range for hypothyroidism is a lot different for our elderly. Okay. This slide we talked about last time, but we're over on the right. You see a lot more hormones that we're going to talk. We're going to talk about every single one of these. Now, this is a busy slide, not anything you need to memorize, but you can use it as a tool at the end of this block and even maybe come back to it for part of the second block because it just kind of summarizes all the things that are going on with the hypothalamus and the pituitary. And look, we already know posterior pituitary, we've got that, right? ADH and its role with the kidneys. And then we're going to start today with the anterior pituitary and its hormones. Regarding the hypothalamus hormones here at the top, right? So we have they're releasing and inhibiting. I don't talk about these that much. I just need you guys to understand that again, the hypothalamus is that control center, helping control the anterior pituitary's response to with hormone synthesis and release. Okay, and luckily, the names tell you exactly what they're doing, right? Prolactin releasing hormones, right? It's telling the pituitary we need more prolactin. Growth hormone releasing hormone. Growth hormone inhibiting hormone, right? Then it's in the name, so I do appreciate that. But don't memorize that. There are a few times where I need you to understand the hormones released by the hypothalamus, and they'll be really evident. Okay, just know that anterior pituitary isn't just doing what working on its own, right? It's in conjunction with the hypothalamus. These are all things we're going to talk about. We'll weigh FSH and LH. We'll hit a lot more in the second block, and then the melanocyte stimulating hormone. We talk about that just a little bit here, just a little bit. And that's just how it plays, if there is a role in that with Addison's related to cortisol. So I like this table a lot, and I kind of, I snip it and put it in some of the slides down there. But you have at the top your hypothalamic hormones. Again, I don't really talk a ton about those. And then from there, though, you have your anterior pituitary. You guys need to know these and where they go, right? So anterior pituitary releases prolactin and goes to the breast tissue, right? Thyroid, it synthesizes and releases TSH, goes to the thyroid gland, the primary gland, where it produces hormones, okay? Right. So again, this one should be, by the end of this block, this should be easy. Definitely review now, but will be easy by the end. So, right here is the common, we know that thyroid releasing hormone goes and signals TSH to the thyroid gland, right? Like we know that path. But of course in medicine, there's outliers, right? There's exceptions. And so there's a few exceptions that I need you to know because they help you clinically too. And they're called the common cross-reacting HPA hormones. So these are exceptions. So again, thyrotropin releasing hormone stimulates prolactin as well as TSH. So we're gonna talk about what that looks like. But that just means that someone with thyroid disease can also have elevated prolactin. Same with ACTH. So ACTH, if it's in excess, it can stimulate melanocyte stimulating hormone, or MSH. And so that's why people with Addison's disease have the darkened skin. Okay, it's because of this common cross-reacting pathway. Prolactin, if we have excess prolactin in the blood, it inhibits LH. So that's super, super important when we look at how these patients present. Okay, so for sure that I'm going to give you lots of examples of how those three make sense. And the last one I kept on here. I don't hit it home a lot. As far as in clinical cases throughout this course, but growth hormone growth hormone inhibiting hormone, or somatostatin, can also inhibit TSH. So all I need you to know that is if someone has something funky with their growth hormone, you need to also check their thyroid. Okay. Instead of going deep down into that pathway, just understand those two together. Okay. And look, we took this fun slide and we made this even more fun, right? So we have the thyrotropin releasing hormone. Yes, we know it impacts your thyroid, but it also can stimulate excess prolactin. ACTH and MSH, they're on the side. And then the blue is your inhibition. So if I have too much prolactin, I'm going to inhibit LH. And then we talked about growth hormone and TSH relationship. Questions on this access and the kind of exceptions to the rules? Really only 3 big ones, and you'll have clinical examples, so hopefully it sticks. So a lot of what we're talking about today is tumors or adenomas. So we learned last week, adenoma is a benign enlargement of a cluster of glandular cells. Now these cells can secrete hormones. They don't always, but they can, and they're typically benign, right? I don't care about the data, but just know they're found incidentally, especially the microadenoma. So micro is small. I'll give you the dynamics for that. And then there's non-functioning, right? So we have, yes, they're capable of secreting hormones, but they don't always do that. And then at the top, it accounts for up to 15% of tumors. Right? So they're all anterior pituitary adenomas. So 2 classifications, so clinically functioning and non-functioning, right? So they're secreting at least 1 hormone versus don't secrete any. Makes sense. And we're going to talk about the top 3 here related to functioning adenomas. And we're talking about them because they're on the names and they're the most common things that you'll see. So here's your micro versus macro. It's all about 1 centimeter is the difference. So microadenoma is less than 1 centimeter. And again, you're finding these because they're coming in presenting with issues from that excess secretion of prolactin, prolactin, growth hormone, or ACTH, or they're found incidentally on an image maybe. So you're working someone up for headaches or dizziness, and you find an adenoma incidentally, and then obviously on autopsy as well. Macroadenoma is over 1%, and these guys tend to be more aggressive versus functioning. Why? Why do you think they're more aggressive? Bigger, right? Is there a lot of space? And then the cell there's not a lot of space. So then you have these space occupying effects. So headaches, maybe so vision changes, cranial nerve issues, right? So that's why they're tend to cause more problems. And you want to work them up fairly quickly. So imaging for pituitary adenomas is very straightforward. It's an MRI. When in doubt, it's an MRI. Okay. How big is the pituitary? It's really, really small, right? 10 by 5 millimeters. So we like the MRI. It shows a better picture. Yes, a CT, especially if the adenoma is big, a CT can be helpful, but MRI is the study of choice. And here's the who's worked in the ER before? Yeah. What do you use in the ER if someone comes in for like a headache? It's CT, right? Tube of truth in the ER. So again, this isn't usually something that's going to be done in an MRI. It's going to be done by primary care. Okay. So maybe on their way to endo, you can see why MRI is just a better image. Oh, sorry, pituitary. I'll show you. You guys know where versus there. So you can see more going on. So it's another. Let's look at these together. Anybody see the microadenoma? I'm sure it's already in your slide. Microadenoma in the top one. So it is. So up in this range, I don't know if I see anything funky, to be honest. But do you see how the second one looks real different? Like that doesn't look normal. And then this is the, oh my goodness, adenoma. Like that they definitely are having problems. And then of course you have, I guess, your arrow side. And you're not expected to read an MRI on your test. As obvious as some things going on, you're not. I don't read MRIs or pituitary MRIs anyway, so you're not. But I just need you to know when you would order it, okay? Yeah, we alluded to this already, the space occupying effects. This should make sense, right? They're going to come in with headaches, cranial nerve issues, peripheral vision loss. Because of, as the adenoma gets bigger, it compresses on the optic chiasm. So here's lovely Netter, just that close-up anatomy reminder. And see how close it is to the optic chiasm right up there. So as that gets bigger, we're going to see typically bitemporal hemianopsia. So where are they coming in? What can't they see? Peripherally, right? So they're going to lose that peripheral vision. That's all I need you to know. You can. Oh wait, neuro, you guys are studying this right now, right? Or is that last test?
Last test.
Last test. Okay. All I need to know for endo is as the adenoma gets bigger, they're going to you need to check for peripheral vision loss, and they may come in for that. Okay. Based on the location of the pituitary with the visual pathway. Treatment for adenomas is there's some overlap. So typically, for most adenomas, it's surgery. And we'll talk about what that surgery is in just a minute. But of course, there's just one exception, because it's medicine, and that's prolactinomas. So when someone has a prolactinoma, we're going to try medical treatment first, okay? So the way I remember it, prolactinoma, try prescription, a pill, however you want to do that. So prolactinoma, we're going to do a pill prescription before surgery. And then the third option, surgery, meds, is the third one is radiation. We'll talk about why we don't use this that often. It's definitely third line, and we'll talk about why in a minute. Now, when I teach you guys this, this is from current, and it's going to be first line, second line. We do that in clinic. It's not always that clear cut, okay? So I just have to add that. On my test, it'll be very clear cut. But we do individualized care when someone comes in. Maybe they're pregnant, or when you tell them about the surgery, there's like no way you're going to do that to me. So there's, even though there's like first, second, and third, in clinic it varies, right? The patient plays a role, and there's other things that go to that clinical decision. Okay. All right. Any questions? Okay. We're going to jump right into the prolactinoma. Lactotrophic adenomas. What's lacto refer to? Milk, right? So what do these people have? Milk, yeah. They're expressing extra milk. Trophic has to do with like nourishment and growth. So prolactin is normal, right? This is, again, we're talking that prolactinoma is excess, right? So we need prolactin for lactation and stimulates milk production, right? So it's important for our female patients who just had a baby. The regulation of prolactin is unique. So it's actually inhibited by dopamine. So if dopamine wasn't there, prolactin would be continuously secreted. But we have dopamine that inhibits it. So the cool thing to remember for treatment for prolactinoma, we're going to go to a pill first. And we have these dopamine agonists that we use for treatment. So do those meds look a little familiar? Maybe I don't know which one. Pergoline, chromocriptine. We're going to talk about these a lot, but we're going to use we know that prolactin is inhibited by dopamine. We're going to give them a dopamine agonist. And here's that pathway again. That helps you visual learners. So, like we said, prolactin's normal. When we're pregnant, prolactin should be released, right? Breastfeeding, sweet. If you have like breast augmentation or reduction, you get your nipple pierced, any kind of thing like that. Those procedures, elective or not, can trigger prolactin release. Exercise, weirdly enough, can trigger prolactin release normally. REM sleep and stress, and then chronic chest wall stimulation. So what's an example of an active duty member or patient would have like chronic chest wall stimulation.
Body plate.
Yeah, exactly. So in the past, the body armor and the plates used to cause this quite more frequently than they do now. So knowing this, knowing that nipple piercing augmentation, breast stimulation causes prolactin, if I see someone and I'm worried about them having excess prolactin and I do a breast exam, will that breast exam potentially alter my lab? Right? Because just the idea of, and then of doing a breast exam can stimulate prolactin. So just things to remember. You can tie this normal into clinic. We have abnormal causes, right? So prolactinoma, right? That's the topic we're in, right? And a prolactin secreting adenoma in the pituitary. That's what we're going to focus on. And then hypothyroidism. So this is our first discussion of the cross-reacting hypothalamic pituitary axis hormone. So remember, so if you have somebody who has hypothyroidism, that they have, what does that mean? Hypothyroidism, thyroid hormone is low, right? So then, because it's low, negative feedback, TRH and TSH are high. That high TRH can stimulate prolactin release, okay? So we'll talk about what to do in that situation. Okay. So again, these are benign, 80% are functional, so they're gonna come in with symptoms. And then our second exception to the rule is that as prolactin goes high, so I have high prolactin or prolactemia, we're inhibiting LH. And we'll talk about what that looks like in presentation. So this is our pre-menopausal patient. They're going to have irregular menstrual cycles. Typically, so either they're not going to have any period or any menstrual cycle, so amenorrhea, or oligomenorrhea, where it means it's decreased, okay? Infertility for sure. So if I'm messing with LH, then it's going to impact estrogen and fertility, right? So sometimes they may come in for irregular menstrual cycle, or they may come in because they can't get pregnant. Galactorrhea, what's that? Oh, I guess I told you. It's right there, sorry. Spontaneous milk secretion, right? Outside of pregnancy. And then here's that LH deficiency. So if I have less LH, I'm going to have less estrogen. And so then I have maybe a 30-year-old female who's starting to present like she's postmenopausal, vaginal dryness, skin changes, irritability, low sex drive, mood changes. So they're going to come in presenting like that, but at a much younger age. Osteoporosis and osteopenia, this is a really big thing because as I decrease estrogen, I'm at risk for osteopenia and osteoporosis. So we definitely need to screen these people for that if they're not going to undergo treatment. Does that make sense? That's related to the low estrogen. Postmenopausal women is a little bit tricky, right? Because they're already in this hypogonadal state, so they're used to all this fun of this low estrogen LH deficiency, right? They're already living that, but they so a lot of times they might kind of ignore it longer, and so potentially they're going to come in with like headaches and visual changes. A lot of times when we're working people up for menopause, prolactin is a hormone that's usually added in there too. Now men get prolactinomas too, and they're going to come in typically for that LH deficiency. So low libido, right? Erectile dysfunction. Maybe they've tried ED meds and they're just not working. They're not responding. You can think of this. Gynecomastia, what's that?
Breast tissue.
More males get breast tissue. And they'll come in, maybe they're going to come in for that. Or infertility. A lot of times guys ignore their signs and symptoms. Maybe because they have Viagra or they dismiss the gynecomastia because they've gained weight. But headaches and visual field disturbances are really common in males because they're more likely to present with macroadenomas. Right? So that's that mass effect. Any questions on that? Do you see how LH plays a role in both males and females, right? So because they're coming in with the libido, infertility, irregular cycles, things like that. Right. So we do a physical exam, we get a good history. What kind of labs do you think we get for these patients? Prolactin, right? It's an excess. This is prolactinemia, right? So they have hyperprolactinemia. So we're gonna just check the prolactin level. It's a hormone, and so it's a little finicky. So if it's abnormal, we always have to repeat the prolactin. If I have a premenopausal woman come in and she has having irregular menstrual cycle and galactorrhea, I'm going to roll the pregnancy test too, right? And we want to always do that. And then why do I want a TSH and free T4? Yes, the cross, right? Because if they have hypothyroidism and they're high prolactin, these symptoms and the prolactin is high, I need to manage that thyroid first. Maybe it's not an adenoma, right? It's the thyroid. And then the CNP, it's included in cribs for liver and kidney function and things like that. The next two, I haven't taught you guys about, I won't teach you about testosterone until the next block, so that these next two are FYI, but I hope they make sense, right? So LH and FSH because of the prolactin, right? Excess prolactin inhibits LH and FSH, so we would expect estrogen and testosterone to be low. Those are kind of intuitive, and I added them on there just to kind of like hit home that low LH. So we get a serum prolactin, and normal is less than 20. But again, don't check right after a breast exam. We talked about that, right? Also, biotin, it's a supplement in a lot of hair, like hair supplements, a lot of collagen supplements. Biotin is it's notorious for messing up a lot of hormones. So possible, you can have the patient stop their biotin or their collagen supplements for a little bit because that can inhibit the lab. Those are the biotin ones, FYI, but not the breast exam. And then you have to repeat it because it's finicky and various things, right? Remember, my physical exam could have caused the prolactin to go up, stress, REM sleep, exercise could have caused it, so we just want to double check it. And then there's additional labs that you'll do as well. Any questions? It's kind of nice when we can just check the actual lab. And then what imaging should we do? MRI, right? Yep, pituitary adenoma, MRI. If I have somebody, if their labs came back and they have hypothyroidism, should I do an MRI? Maybe not, right? Probably, I want to treat the thyroid disease first. But if their TSH and T4, free T4 is normal, absolutely you can order an MRI. And in that you should see the adenoma, okay? Any questions about imaging? It's going to be pretty much the same for all these adenomas. MRI all day. There's your adenoma. It does not look good. This is your macroadenoma. So this would be more common in a male or female? Male, right? They're having and versus regular. Okay, so treatment. So treat the underlying problem. So if they have some medication that is known to cause excess prolactin, we should probably stop that. Do I have any list of those meds in here? I don't. That's intentional. Which obviously you're just remembering to, if there's a med, you want to stop it. But absolutely, if they have underlying hypothyroidism, we need to treat that first. Okay? We need to treat it with levothyroxine and then follow up labs 6 to 8 weeks. And we're going to not only follow up the thyroid, but we're going to follow up the prolactin and see if we fix it. Because we can fix it with just levothyroxine, giving what the body needs versus throwing a dopamine agonist on it as well. Okay? So treat the underlying cause first. But say we have and this is why. But say we have a patient and we do a serum pregnancy test, they're negative, we do prolactin, it's elevated, TSH, free T4 are normal. We repeat the prolactin and it's high again, so we're like, okay, I'm going to order an MRI for this patient. MRI shows a prolactinoma. How do we treat? With a pill, right? We're going to do a pill prescription. We're going to use our dopamine agonists. Why? Why dopamine agonist? Yes, it inhibits. We know this. We inhibit it. So we have our two, cabergoline, bromocriptine, The coolest thing about this, guys, is you give it to them, and 50% of people, or sorry, they'll have a reduction in the adenoma size by 50%. So it'll shrink by 50%. And then up to 90% have their prolactin levels normal. So if my prolactin level is normal and no longer excess, then sweet, as a male, and hopefully my fertility improves, my erectile dysfunction, my libido, gynecomastia, all of that stuff improves. For a female, I go back to a regular menstrual cycle. I'm no longer this postmenopausal funness. I don't have to deal with that, right? So this is awesome, and why we're going to go to a pill or a prescription before surgery. Okay. And then I think, yes, I have a page. This is a patient, so A is obviously abnormal, right? So we have that adenoma. And then they had caperculin for how long? I don't know, 6 months? 6 months. And look at it. Look, you can, I mean, I'm not a radiologist, but clearly way better, right? And then hopefully their prolactin levels decreased. I think they went down to 15, so it was normal. It was 8,000. Yeah. So typically when people have hypothyroidism, their prolactin will be high, but not like 8,000. People with prolactinomas have significantly elevated prolactin levels, okay? Because again, you have the adenoma just spilling out prolactin, doing what it wants. Now, so you have a patient who for whatever reason can't tolerate dopamine agonists. Does anybody remember the side effects to dopamine agonists? What is it? EPS? What else? So usually you'll give it to them at night if you have dizziness, orthostatic hypotension. It can make people like impulse control issues, so or even like depression, hypersexuality, all these things. So if you tell somebody that, they're like, nope, I don't want to do that, I want to go to surgery, or they try it and they can't tolerate it, then our second line is surgery. Okay? And again, so if they're intolerant, unresponsive, or they can have that macroadenoma, it's that male patient where they have significant peripheral vision loss, headaches, we want to go to maybe the surgery. So with any surgery where there's going to be risks, before we go into the risks, let me show you the surgery. It's kind of unique. Transsphenoidal resection. So yeah, so they go through the nose, the septum, and go in there and suck that adenoma out, or cut it out. Anyway, but so anybody guess how long ago, or how long have they been doing this? When did the first transsphenoidal resection happen?
20.
20? Wait. 30. Longer. 100. More. I know. 1907. Yeah. So we started washing our hands in the late 1800s, like 1886. So at least we had that box of stuff. Okay. So we did at least do that. But it was Dr. Schulfer who was the first one, and then good old Dr. Cushing, who will haunt you for my first block. I'm sorry. He mastered the procedure in 1927. I don't know, like, who volunteered for this? Like, that's anyway, so medicine's super cool. Yeah. So, and then again, obviously, so we see the picture, and then it kind of makes sense. So there's risks, obviously, when we're doing a procedure like that, where we can stir up trouble. Obviously with meningitis, strokes, infection, that sort of thing. And interesting enough, diabetes insipidus is common 2 days post-op, and SIADH anywhere from like 4 to 2 weeks after. 4 days to 2 weeks after you can have it, and it's usually self-limiting for both of those. Because we're messing with the pituitary, the posterior pituitary kind of gets triggered. Okay? Questions on this? So we have prolactinoma. We're going to do our dopamine agonist first, then we have our transsphenoidal surgery, and then last but not least would be radiation, but thankfully we rarely use this. And the reason, so greater risk for panhypopituitarism. So that means like widespan hypopituitary. What does that mean? Low, right? Hypopituitarism. So that means all of my lovely important pituitary hormones go low. And the reason is, so we have a lot of radiation has come a long way. But remember that pituitary is real small. These adenomas are real small too. So we like this. That's why this is saved for people who fail other treatment. Okay. Any questions on that? Prognosis, they do well. Again, 50% of people have the adenoma shrinks by 50%, and 90% of people have normal prolactin levels with dopamine agonists alone. They're going to be monitored. Obviously, complications are associated with those macroprolactinomas, specifically in males. And then there are, if for whatever reason a patient decides, I don't want meds, I feel fine, I don't want to do anything, you need to make sure that you screen them for osteoporosis. Now we screen women for osteoporosis, but if you have a male, maybe you find an incidental prolactinoma and he feels fine, this is a time where I would get a DEXA scan on a male. Does that make sense? All right, so we're at 42 after. Do you want to take a break? Yeah, and then, yeah, okay, afternoon. You got them. Okay, and you have like Halloween candy waiting for you, right? Lots of it. All right, so switching gears. So prolactinoma, now we're going to go to the somatotropic adenoma, or a growth hormone secreting, right? So it's the second most common secreting pituitary. And guess what? 15% of those with the growth hormone adenoma also secrete prolactin. Okay. On the test, I will only give you one adenoma. I won't throw two at you. Just a review of the feedback loop for growth hormone. So we have our anterior pituitary releases growth hormone, and it goes to the liver and other tissues throughout the body, and it's converted to IGF-1, or insulin-like growth factor 1. And once growth hormone levels are where they're supposed to be, that feedback loop, negative feedback loop, adjusts. Okay? So we use IGF-1 for our lab, and we'll talk about why we use that instead of doing a lab for growth hormone in just a few minutes. Okay, so just said this, growth hormone is converted to insulin-like growth factor, so again, we utilize that when it comes to our labs. Growth hormone is a big deal, right? Development, metabolism, lots of things, skeletal muscle, adipose tissue, lipolysis, what else? Behavior, right? If your growth hormone is often can impact behavior, soft tissue, obviously growth, right? Your longitudinal bones, things like that. So, what did I miss? Skeletal muscle, anabolic actions, behavior, metabolism, right? It plays a role with insulin and carb metabolism. So it's important. We know this, yeah. Anybody fans of baseball back in the 90s? Barry Bonds, hormone, yeah. So he is known for taking all sorts of hormones, but specifically growth hormone. And potentially it's the change in his, not just his muscle, but his head potentially is related to growth hormone. But again, so people will use this for the anabolic effects as well. Makes sense. It's important to understand what stimulates growth hormone and what inhibits it. So sleep, exercise. So sleep's important, right? We need, if we get good sleep at night, the growth hormone can do its thing. Exercise triggers a release. If you're sick, you can have increasing growth hormone. And then blood sugar, when blood sugar dips. Same on the opposite side. The big thing on here is I think glucocorticoids. Knowing if you're taking glucocorticoids, that can inhibit growth hormone. Obviously increased IGF, right? As IGF goes up, we're going to inhibit growth hormone through that negative feedback loop. And hyperglycemia. So knowing that hyperglycemia, so high blood glucose, inhibits growth hormone, we're going to use that in the lab, and we'll talk about that in a few slides. So we have a lot of growth hormone as we're growing, right? Once we stop growing at puberty, it slowly starts to decrease, right? Because we don't need to grow anymore. Growth hormone is released in a pulsatile manner, 8 to 12 pulses per 24-hour period. So this is why growth hormone is it's a really hard lab to draw, right? So if I draw, so growth hormone peaks in the evening when we're asleep, so I'm not going to get someone's lab in the middle of the night. But we know exercise can trigger it, like an acute illness, which is harder to control. So, and then we know it's pulsatile. So if it's pulsatile release, it's just really hard. We can't do like morning labs or fasting labs. None of that helps. So again, we're going to lean on the IGF-1. Okay. So pulsatile, no good. So we have two types of disorders related to somatotrophic adenomas. So growth hormone secreting adenomas. Growth hormone's too high, right? So gigantism. This happens when we're a kid. So our bones have not fused. So our bones grow really, really long, like this gentleman here. Versus when it happens when we're an adult, we're going to see very different signs. Right? We're not going to grow taller, but we're going to have changes in our hands, our shoe sizes, our hat sizes. Huge scary thing is the impact it has on our internal organs and our cardiovascular disease. So let's briefly talk about gigantism really quickly. So this guy, Robert Wadlow, is the kind of the most famous guy for gigantism. Look at his height. He was 5'4", and then jump a few years ahead, he is 6 foot at 8 years old. Yeah, so he's already taller than me. At 10, he's 6'5". So yeah, so huge difference in how gigantism presents pre-puberty than acromegaly. So he actually died not due to like his cardiac issues, but it was through sepsis, something he had at brace. He died from that, but I think in his 20s. But there you go. That's all I got for gigantism. So what I care more about is acromegaly. So let's look at this patient over a 9-year period. So we have patient 0, no, just kidding. 1997, this is what she looks like. How does it change between 1997 and 2004? How does her face look different? Nose? Yeah. How about from 1997 to 2006? Yeah, like maybe her jaw looks a little bit different, but definitely like the fleshy nose. But you can see, I mean, with her, when we just look at the face and a female, it's not super specific versus the Happy Gilmore guy. That was more obvious, right? So just understand this, this is an insidious process, meaning that it happens slowly over time, and it takes a long time for it to be diagnosed. And then obviously, you guys got your MRIs down by now. You can see what is abnormal right there. Not good. So, signs and symptoms, we're going to have widened fingers and widened feet. So their ring sizes are going to change, their glove sizes, their shoe sizes. Hyperhidrosis, what's that? Sweaty, yeah, so sweaty palms. Carpal tunnel syndrome. Why would someone with acromegaly, excess growth hormone, have carpal tunnel syndrome? Right, so there's a median nerve. Yeah, from probably the soft tissue swelling, potentially, right? There's a little tunnel here. So that definitely can be a cause. Also, pregnancy can cause carpal tunnel syndrome, diabetes, all sorts of good stuff. Probably the most classic thing is these coarse facial features. So frontal bossing is that prominent forehead. It was kind of hard to see on our female patient. But the large fleshy nose, their lips will get bigger, and if you have them open up their mouth and stick out their tongue, you would have an enlarged tongue as well. And then this malocclusion and prognathism. So it's where the jaw protrudes forward. It's easier to see on others. And then their teeth don't align anymore. So you're going to have, that's what the malocclusion has to go with. Okay? So these are classic signs. And then again, I already alluded to this, the median time to diagnosis is 10 years. So it happens so gradually that sometimes the people around them don't notice. Or maybe it's how they age or things like that. So you can always look at an old driver's license picture or old picture on their phone to maybe confirm your suspicions. kind of a comparison of the two. Here's that jaw, where it's the lower jaw is pushed forward, the frontal bossing, and then kind of the, again, we'd have to compare, but the fleshy nose and the jawline and lips. Here's the hands, normal versus acromegaly. Definitely like the lower left, that's suspicious. And then I just kept the lower right picture. Obviously they're two left hands, so it cannot be the same person, but there you go. Definitely not the same person. Okay. So this to me is what you don't see just by physical exam, but what you need to care about is PCMs, the cardiovascular risk. So we have excess growth hormone. We talked about all the soft tissue and the bone changes, but it impacts the organs too. So hypertension, cardiomegaly, and sleep apnea. We care about those a lot. 50% of people who are diagnosed with acromegaly already have hypertension. Diabetes, insulin resistance, obesity, or weight gain is a huge factor. And then they might have ED, myopia, or muscle pains is pretty common, headaches, and colon polyps. So if I have someone with acromegaly and I look at this list, I'm going to order an echo. Obviously the MRI, we know that, and labs, but I want an echo on this person. I want an A1C. They don't already have diabetes. A lot of them will already have diabetes and hypertension and obesity. And then I want a sleep study, if I don't already know they have sleep apnea, and I want a colonoscopy, okay? So even though we as PAs aren't going to be necessarily managing the endocrinology piece for acromegaly, we're managing this stuff. Does that make sense? And we can start the screening for these patients while they wait for their endo referral. So, organ enlargement too, and know the complications of that. Any questions on that? This one's more obvious, from 16 to 33 to 52. A lot of these people, they'll have their hands in the photo to show the enlargement of the hands. It's like a common thing. All right, so we got our physical exam, we've got a good history. What do we do next? An endo to work up. We're thinking it's acromegaly because they're gross features, they have hypertension, diabetes. What do we do next? Labs, yeah. So we have, we already know this. Why are we checking growth hormone? We can't, because it's an excess, right? And it's pulsatile. So if I check growth hormone, it's not going to be value added, right? So instead, I'm going to do IGF-1. And first we're going to do a random IGF-1, and if it's high, then I need to repeat it fast. Okay. All right. So just like the prolactin, we repeated the hormone level twice. So in addition to that, I need to do a glucose suppression growth hormone test. Okay. Endo labs. Stay with me. So do you guys know? Are you familiar with the oral glucose tolerance test? A little bit. So it's like you drink this gross sugary syrup, and then you check your blood glucose to see what happens. So it's the same idea. So we know hyperglycemia should inhibit growth hormone. So we learned that a few slides back. Okay. So what I do with this patient is I'm going to give them the gross glucose syrup, but no matter what they say it tastes like, it does not taste like orange soda or grape soda. It's gross. And then I'm going to measure their growth hormone. And I'm expecting in a normal person, their growth hormone will be low. So an acromegaly person, it's elevated. Okay. So again, it's usually on the pants, they might call it oral glucose tolerance test or glucose suppression growth hormone test, but the lab tells you exactly kind of what it's doing. Does that make sense? So we're using what we know about the hormone when we do the lab workup. Any questions? Again, I put this down here. Serum growth hormone is limited by the pulsatile triggers. You can't exercise, right? Because exercise stimulates growth hormone. You can't like have any kind of acute illness or stress, so again, not ideal. Imaging, no surprise, MRI, right? Pituitary MRI. Differential, okay, if that helps you, great, but we're not going to test you on that stuff. So what do we do for treatment for these guys? For lactinoma, we do a pill. What about everybody else? Surgery, the transsphenoidal resection, good old Dr. Cushing, so we're treatment of choice, and it works for 70% of patients. Improve. Growth hormone levels potentially will fall right away, so you have to monitor that, as well as their they might need steroids right after the surgery. So remember, you're messing with the pituitary, you're ideally just getting the adenoma, but their hormones will have to be monitored right after that surgery. If you do surgery and they're still struggling, then you can do different treatments. Did Pharm go into the somatostatin analogs at all? Okay, I don't dive too much into them. I just kind of need you to know that there are options, medication options. I need PA heater. I'm not prescribing these for acromegaly, but you can use a dopamine agonist. They're, especially if you have someone with growth hormone, adenoma, and excess prolactin, but then you have your somatostatin analogs and your SERMs. So it's expensive, some of these meds. Even somatostatins, I don't know if the price, they're pretty pricey too. So just know there's medication is second line, okay? And then obviously we have our radiation if that fails. But significant risk, even higher risk for hypopituitarism, right, where the pituitary fails after radiation. So these patients do pretty well after their transcranial resection. Their soft tissue, so the fleshy nose, the hyperhidrosis, even the enlarged tongue, carpal tunnel, all that soft tissue stuff should improve. But we can't help if they have the frontal bossing, and I'm not sure about the malocclusion, I need to look that up, but the bony stuff doesn't change, but the soft tissue stuff. Cardiac risks, who do you guys think of that? That's who manages that, Indo or you? You guys, yeah. Hypertension typically persists. 50% of them or more have it at diagnosis, and it continues after. Sleep apnea persists, okay? So that's really important to know. Any questions on that? Even though we're not the ones doing the surgery, when we boot them to endo, we could be like, hey, they're probably going to do a surgery. 70% of the time it works. The soft tissue changes should improve. However, we're going to keep managing your hypertension. Okay? Any questions? All right. Switching to corticotrophic adenomas. This is our third and final, functioning adenoma that we'll talk about. We will talk about Cushing's now, and we're going to talk about more Cushing's in lesson 5. So Cushing's is excess what? ACTH secreting cortisol. Yes, excess cortisol. So we need cortisol. It's super, super important. We're going to dive into why cortisol is important in lesson 5. But I'm going to try to intentionally just stick with the adenoma in this lecture. Okay. So we have our third most common one, more often in women, and they're usually small. That stuff isn't testable. It's just to kind of help you differentiate. So Cushing's syndrome. The term Cushing's syndrome is specifically you have high cholesterol in the blood. So elevated serum, cortisol, not cholesterol. Elevated serum cortisol is Cushing's syndrome, okay? Cushing disease is specific to ACTH-dependent hypercortisolism, okay? So, Cushing disease, the problem is in the dome, right? So we have an adenoma, Cushing disease, dome, 90% of the time it's dome. ACTH dependent, so I got dome, I got disease, and I got ACTH dependent, all right, all to help you. What do you think ACTH dependent, what does that mean? Like in regards to high cortisol? Yeah. It's triggered because there's excess ADH from an adenoma that's filling out excess ACTH, that's causing the high cortisol, okay? There's there's ACTH independent that we'll talk about later. But again, this is due to an adenoma in the brain causing excess ACTH, which by default causes excess cortisol. Right? 90% of ACTH dependent causes are pituitary adenomas, which is this topic. And then of course we got 10% are ectopic. And those are typically like it's a non-endocrine, often cancer. You have to look somewhere else besides the endocrine the system for it. Make sense? Terminology we've heard before. Here's your feedback loop. Again, we need ACTH, right? We need cortisol, helps us in stressful situations. It helps us in day-to-day life. It helps you through IPAC, turns out. So again, we have the anterior pituitary is signaled that cortisol is low, so it's going to secrete ACTH. ACTH then goes through the bloodstream to the adrenals and the adrenal cortex, and the adrenals do what they're told and produce cortisol. And so we get that homeostasis point, and then it decreases the ACTH. In this problem, in Cushing disease, ACTH dependent, it's an adenoma that's causing excess cortisol. Okay? Any questions? We'll talk about this again and again so you guys get it, or I'm available if you don't get it. Please come see me. Because it gets, if you might hear, you're like, I get it, and then you get on the test and you're like, I forget it all. So anyway, so again, this just talks about that umbrella. Cushing syndrome is high cortisol. Cushing disease, 90% of the time, is an adenoma in the dome, in the pituitary, and then Cushing syndrome, the problem is in the adrenals. But clinically, they look exactly the same. So that just tells you we're going to have to use labs and imaging to help get to the diagnosis, okay? Not just physical exam. All right, this is what these people look like. I don't like to read slides, but I will go through this a little bit. So this is also slow. So usually around 5 years to get this diagnosis. And we look there is fatigue. Central obesity, it really is around the belly, but where do men gain weight? Usually around the belly, so you can kind of see where it'd be harder for a few can miss this on a male. What is a plethoric moon face? What do you think plethoric means? Redness. They'll have like a red moon face in the swelling of the cheeks. Supraclavicular fat pad and a buffalo hump. What's a buffalo hump? Yeah, exactly. So the dorsifcervical fat pad, for sure. Thin extremities with muscle atrophy and proximal muscle weakness. Is the patient going to come and say like, hey, yeah, I have proximal muscle weakness. I think I have Cushing. No. What will they come in and say? Yeah, like weakness, maybe hard time getting out of the car or picking up their kids. Easy bruising and delayed healing, that's a really common one, so these guys are going to get bruising. Purple striae, we'll have photos of that, but that is a very classic Cushing finding. So if you have someone come in and you don't lift up their shirt for Cushing's, are you going to be able to see a buffalo hump? Potentially not. Supraclavicular fat pads, maybe not. Bruising, all of this stuff really kind of relies on like a really good physical. It can impact erectile dysfunction, there's menstrual cycles, skin, like kind of thin skin. They're more prone to fungal infections. And this should be no surprise that hypertension is a really big thing. So a lot of these patients already have hypertension and already have diabetes because does this come up fast? No, this is diagnosed over like 5 to 6 years before they kind of either trigger their PA to work them up or they get sick. Here's a lovely picture if this helps you know all of the lovely signs and symptoms of someone with Cushing's. This is your purple striae. So very different than, you can get normal stretch marks, but those are usually more flesh colored or skin tone. These are darker. So this makes me laugh. So what is that picture of on the right? Yeah, but look at that guy's jawline. And look at his, like, he's like, anyway. So there's your buffalo hump picture. Okay, so we have an 18-year-old male. He comes to see you. He's feeling depressed. And he's been struggling with low back pain, second to vertebral fractures. He's also had a 20-pound weight gain over 2 years. What do you guys see? Just on his face.
Moon face.
Yeah, moon face. But could this just be weight gain, right? So just understanding that, yes, most of the time obesity is just obesity, but it can be hard to see Cushing's. But yeah, so he has the plethoric moon face. Do you want to see more than just his face?
Yes.
Yes. I want to evaluate for hypertension, diabetes, ask us some questions about muscle weakness, maybe look for bruising, and of course, central obesity and purple striae. So here he is again. This is him. So A and C are pre-treatment, and B or D are post-treatment. So he had the surgery, the transsphenoidal resection, and you can see it looks very different. Yeah, very different. Obviously, the purple striae kind of still stay. Okay, so that's just to get perspective. So we're going to jump in, talk about signs and symptoms, physical exam, correlation, and now we have to go about labs. And then it's another fun endo test, or endo lab. So I'm going to walk you through what it looks like normal, and then we'll talk about all labs together. Okay, so if I have a patient and I give them steroids, I give them dexamethasone, okay? What, if I give them dexamethasone, what happens to ACTH? It's gonna up or down? Down, right? Because dexamethasone, I gave them steroids, so that goes, so ACTH goes down. Perfect. All right, negative feedback. So what then, because of that, ACTH goes down, then the adrenals are going to make less cortisol, right? Because they're just doing what they're, yes ma'am, I'm just going to make my cortisol, right? So they're going to make less cortisol. So if I give this patient dexamethasone before they go to bed, and I check their cortisol in the morning, what should their lab be? Low as well, right? This is a normal person, low, okay? Now, we're not talking about normal, but we're going to use this normal on a test and just to, figure out what's going on with our patient. But with Cushing disease, we're going to have a little bit different action. Because remember, the problem with disease is, where's the problem? Pituitary, 90% of the time. It's ACTH secreting adenoma. So let's see what will happen. So you give them a steroid at night. It's usually at 11 o'clock at night. Anterior pituitary makes less ACTH, right? It's doing what it's supposed to be. Adrenals should make less cortisol. But we have this adenoma secreting excess ACTH. So what does cortisol do? It's high. Yeah, it's always high. So we use our labs and we tie them back to our negative feedback loop, so you don't have to just memorize things. Or you can memorize. That's pretty good. All right. So to diagnose Cushing's disease or Cushing syndrome, you need 2 of 3 initial labs. So you have to have 2 of these at least to get to hypercortisolism. Okay. Dexamethasone suppression test. So that's what we just described. So we have a patient, it's actually really easy. They take the exogenous steroid at 11 o'clock at night, and then they come in first thing in the morning for labs. And we see, we expect cortisol to be low, but in these patients it's high because of that adenoma. Okay, it's pretty simple. And then, of course, it's intense. We're going to throw in another 24-hour urine. Specifically, we're looking at the cortisol and creatinine, and this helps confirm hypercortisolism, right? The last one is a salivary cortisol test. It's somewhat easy to do, but it's not usually offered at the MTFs. Have you guys heard of that one at all? So you can't smoke or eat, I think, or brush your teeth, but you rinse your mouth and you wait a few minutes and then you just collect the saliva in a tube and then they test that. It's also at night. But for whatever reason, I've never ordered that one because it had an MTF. But you need how many of those? 2 out of the 3 to confirm hypercortisolism. So if I'm confirming hypercortisolism and I have a patient who looks like Cushing's, do I know if it's Cushing disease yet? Or no, I don't, not yet. So we'll get there. Okay, so we've confirmed they have hypercortisolism. Figured it out. Now we're going to do the next lab is we're going to check the ACTH. Okay, excess ACTH indicates an adenoma 90% of the time, right? There's that 10% ectopic. Does that make sense? Because it's ACTH dependent Cushing disease, right? So that's that adenoma secreting excess ACTH. Have you guys heard of DHEAS? Dihydroepiandrosterone sulfate. So this is, so ACTH is a really finicky hormone. Go figure. But DHEAS is secreted independently, but it mimics what ACTH does. So it's kind of like a biproxy lab. I don't quiz you on it yet. There's actually research going in, they briefed this at an Endocrine conference this past year, of how maybe we can start using DHEAS instead of ACTH to help with diagnosed Cushing's and stuff. But just so you know, it's another option, but FYI. But you'll hear me talk about it a little bit. It's a very, once it's sulfated, once it has the sulfate on it, it's a very easy, predictable lab. So, big surprise, we're gonna do what? An MRI when it comes to imaging, right? And we're gonna pick that up. Now, there is an additional test where they take, they do a specific test in endocrinology, but we're not going to do it. I'm not going to test you on it. They essentially like sample from the sinuses, and they'll like induce it. They'll give them dexamethasone or other things to kind of induce the pituitary response. But all I need you to know is MRI, and then the labs we've talked about. Treatment, you guys already know this, right? Transsphenoidal surgery is what we're going to do, and it works 80 to 90% of the time. So if I have somebody who had an ACTH secreting adenoma, and it's just secreting out all this ACTH, and I take it away, what do I need to does it make sense why I would want to replace them with corticosteroids, right? Because you've had ACTH is in excess, cortisol is in excess, and then I just take that away. So we need to supplement with corticosteroids for anywhere from like 6 months to 3 years. Okay? So that's really important. That won't be you, that will be endo. Hopefully that makes sense. Any questions on questions? Yeah.
What's the patient medication for steroids? I'm sorry. What is the patient education portion of that?
Oh yeah. So I talked more about this in lesson 5, but so if you have a deficiency in cortisol, it is life-threatening. So that's sick, not sick. This patient without cortisol is very sick. So you want to educate the patient and the family of what to watch for. So what will happen, so we need cortisol when we're sick, right? It helps to increase our immune response, all of that stuff, right? So if we are supplementing with cortisol and then you get sick or you're in a vehicle accident or something, then that's when it's scary. So you want to educate the patient that, hey, if you get sick or if you have some kind of trauma or something, you need to get seen right away. And I talk about it more later too, but great question. Radiation, maybe, and then very rarely, so again, I'm giving you classic patients, but sometimes people will need to have adrenal surgery, but we're going to just keep it transsphenoidal surgery for this test. Okay, you guys stay with me. Again, they do well, 95%, there's your statistics, they do well, but you're still going to be monitored. And then again, hypertension, diabetes, osteoporosis, obesity, you need to monitor patients for this, okay? Especially if they've had excess cortisol for a really long time. When to refer. As soon as that dexamethasone suppression, that 24-hour urine, cortisol is elevated, you're going to bump them to endo. You can absolutely order that MRI and maybe screening for diabetes and things like that. What do you see with this patient? Yeah, she was dismissed a lot. Yeah, she was dismissed over and over and over again, years and years, to just saying it was obesity. This is her post-treatment. Totally different person, right? So again, just like going, listen to your patient. Yes, this is super, super rare compared to obesity. We'll talk about obesity next time. But just remembering to work up your patients. I was listening to this thing and related to this topic, and a lot of times they say just the person who's obese doesn't need to be treated or screened for Cushing's. So that person who's like obese with like significant weight gain over a short period of time, diabetes, hypertension. And I'm like, oh, most of my obese patients have diabetes and hypertension. So just really utilize your physical exam for this is what I would say. But overall, it's rare. All right, so those are our 3 hormone-secreting functional adenomas. Non-functioning is pretty straightforward. A lot of times they're found incidentally, especially if they're small, right? Maybe they're having an MRI or something for another reason and you find it. But because they feel fine, right? As long as it's small enough and it's not causing any mass effect problems, the patients aren't going to be complaining about it. We already talked about how non-functioning macroadenomas tend to be more aggressive. We get why. Microadenomas are asymptomatic versus our macroadenoma headache, for sure. Visual disturbances. Where's my visual disturbance for these guys? Peripheral, right? Yeah. Hypogonadism. So it's like the low T, which we talk about a lot next block. And other things. And we do a workup for these people. Maybe they do an MRI, neuro does an MRI, and they find this incidental adenoma, and so we do a complete pituitary lab workup, and it's all negative. So what do? They have a non-functioning adenoma. What do? Yeah, if it's like too big, we should probably need to do surgery, right? But otherwise, we can also monitor and discuss that with some screening. Pretty straightforward concept. I think that's more common in men too. Questions on non-functioning? Sounds nice and short. All right. So the next topic, if we can push through, is all about deficiencies, and it's fairly quick. I had to add new stuff this year due to the PANCE blueprint. We talk a little bit more about growth hormone deficiencies, but for the most part, it's pretty straightforward concepts. Okay, so it could be isolated, so it could be one specific hormone. So again, we're moving towards anterior hypopituitarism, so deficiencies. So it could be a deficiency in LH and FSH, TSH, or both, right? So you can have multiple. A lot of times it's more than one. Panhypopituitarism is just that global failure, right, of multiple hormones. So hopefully this makes sense. Both the pituitary and the target hormones will be low, right? So we're gonna go to thyroid because we do that a lot. So in primary hypothyroidism, where's the problem? Primary hypothyroidism. Yeah, in the organ of the thyroid, right? And so because we know what we know about negative feedback loop, TSH is high, anterior pituitary is working just fine, and thyroid is low. But in secondary, the problem is where? Pituitary, right? And so if pituitary, the problem is there and it's deficient, we have low TSH and therefore low T4, right? Makes sense? So both are low. Both are low. Which is more common, primary or secondary hypothyroidism?
Secondary.
Primary. Yeah, you're good. Primary is, I treated tons of primary. I've rarely seen secondary, but. Okay. So what the benefit, if we know they're deficient, we can give them what they're missing, right? Whether it's levothyroxine or growth hormone injections. If they're short on cortisol, we're going to give them glucocorticoids. So there's a few topics. There's a lot, I guess, but we're only going to dive into the bolded ones. Okay. So this is a new topic on the PANCE this year. So dwarfism or growth hormone deficiency is congenital. What does that mean? More, right? There's various there's like a lot of genetic issues that I'm not testing you on, just so you know there's the congenital that you're born with versus acquired. Now you see I list the different acquired. There's tumors, radiation, TBI for sure, but most of our growth hormone deficiencies are idiopathic. We don't know. And we catch this a lot in kids. Why would we catch this in kids? Acquired. Yeah, they're growth charts, right? We're expecting them to grow, and they're not. And so we'll use that. Again, congenital is FYI for your situational awareness. But again, they're going to typically appear, have reduced growth length, and have some other issues, okay? So probably talk about that. But acquired, for sure, you guys need to recognize this because you'll probably be doing some kind of sports physicals at some point, for sure in phase 2. Air Force, you guys will see kids. But it's growth failure, right? So short stature, and it's specific to standard deviation below normal. And what do you mean by height velocity? So we measure weight and height and BMI. So it's that we expect the curve to go up when they're young, and so that doesn't do that, right? So our velocity decreases. And we actually, depending on your age, we expect kids to grow a certain height, so a certain number of centimeters for boys and girls in different ages, right? Puberty factors into that. So we're having delayed growth. Of course, we have to rule out other things. So here's that growth chart. You'll practice this in your PEDS lab, but you can see weight is at the bottom. They're doing okay, but that is abnormal or normal on that height. Yeah, it's definitely decreasing. So they were on the bold line in the middle, that's 50th percentile. And then, whoa, we're not even on the growth chart anymore. That is very suspicious for growth hormone deficiency or something going on. So you as PAs in primary care, you're going to use your growth chart, such a high velocity. You're going to get x-rays of the hands. That can help you with bone age. Consider an MRI of the pituitary, and you do a bunch of labs. All I need you to do for this exam is to recognize, if I give you a scenario of growth hormone deficiency, that you can identify the diagnosis. I don't need you to know every single lab or anything like that. And then understand the treatment. Okay, so we give them what they're missing, right? We're going to give them recombinant growth hormone. And interesting enough, it sounds super simple, right? We're going to give these kids growth hormone. But the compliance rate isn't that great. Parents forget, or they're like, oh, they're going to be fine, or they get nervous. So the frequency, I think it's once a week or twice a week now. But they're working, there's a lot that goes into actual treatment for this. But again, as PCMs, you're going to screen, identify there's a problem, do some workup. You don't have to memorize all the labs, but then know when to send and who to send them to. Endo, pediatric endo specifically, okay? We're giving them what they're missing. So I added this slide last block because growth hormone deficiency is a thing, but it's so non-specific. Central obesity, fatigue, concentration issues, depression, reduced muscle mass, like it's very, you guys will hear these complaints all the time, people are struggling with that. And typically, if you find someone, an adult with growth hormone deficiency, they probably have other deficiencies as well. But this is not on your test. It's just put it in the back of your head. Okay. All right. Anterior hypopituitarism, we talked about growth hormone deficiency. Obviously, if there's a CNS disruption, so like radiation, surgery, something like that, that impacts the pituitary gland, we could have deficiency. That's pretty like straightforward, right? But what I think is really interesting and probably not talked about enough is the impact on people with TBIs. Why do I care about people with TBIs? Because you are a patient population. And then we have the people, think about we know known TBIs, right? You had a known incident, but there's people based on their jobs that are impacted and they have small TBIs all the time from maybe blast zones and things like that that aren't documented. So there's certain populations that you're going to take care of that are at risk for this. And it says current says 25 to 30%, but it might be higher. And your patients are going to be the ones that are probably going to be researched on this. So the TBI-related endocrine disorder is your neuroendocrine dysfunction. So essentially you have someone with a TBI and they're just not getting better. They're struggling with fatigue, maybe libido, energy, and things like that. And so if you have a patient like that, you want to do endocrine labs, okay? And you're going to check their thyroid, their growth hormone, testosterone, all of that stuff, because they're struggling, and it's due to this TBI. And it can present up to 3 years after the incident. We were at Egeland, and I had really good friends who were in the Army intense group, so Green Berets, and we would see like change of command. I was listening to all of them, and then throughout the multiple years, I became friends with a lot of these guys. And man, thyroid, low T, thyroid, low T, thyroid, like all these men with thyroid disorders and things that obviously were low T, and I don't know, maybe it was contributed to all the TBIs that they had. They were older, lots of deployments. But again, if you have your TBI patient, don't forget about endo screening. Questions on that? Just all you should do is recognize it, okay? Not memorize the labs, just recognize that there's something going on and I need to work it up. Multiple labs. Sheehan syndrome, have you guys heard of that? So it's a very specific population. And it's essentially ischemia and necrosis of the pituitary. And it happens in women who have a hemorrhage and severe hypertension during delivery, and they require units of blood. And during that incident, they can have damage to the pituitary. And so in the United States, we are aware of Sheehan syndrome, but in other countries, the education and they might not catch this, or maybe the follow-up prenatal care, this may be missed. So it's pretty rare in the United States, but still something to know about. And it's also interesting because you could have this patient who has a really scary delivery, and then years, like 9, 10 years later, then they present with Sheehan syndrome. So the biggest thing is if you're ever in an OB rotation and you have someone who hemorrhages and needs blood, you just need to educate them about Sheehan syndrome and the signs and symptoms to watch for, okay? Again, just identify this. So identify TBI, identify Sheehan syndrome, okay? Can a male have Sheehan syndrome? No. Okay. Sorry. Just trying to, we got 10 minutes. All right. Pituitary apoplexy. This is very important. Something that we have, one of those things you don't want to miss. Emergent, especially in the ER. And it's a hemorrhage or infarction of the pituitary. Usually it's with someone who has an adenoma. We learned about adenomas already. So but it's usually someone with a history of a prolactinoma, maybe acromegaly or something like Cushing disease. And so, but obviously Sheehan syndrome and things like that. So if we have a hemorrhage and infarction of the pituitary, that's the problem, right? Yeah, it's no longer functioning, and these people are sick, and they go to the ER, hopefully. And they have a very classic presentation. So headache, very severe headache, vomiting, visual changes, there can be hypotensive. 95% of them will have a headache. 95% will have hypotension. Vast majority will be vomiting. What do you learn about in neuro that might overlap? A severe headache. Yeah. Yeah. What is, am I teaching you about SAH and AL? But overlap. So again, prompt recognition. I said this again. So severe headache, vomiting, visual disturbance, right? They're hemodynamically unstable. Past medical history. What am I most likely going to hear about in their past medical history? An adenoma, right? We had some kind of adenoma, and potentially, and now we have pituitary infarction. So we're going to stabilize these people with fluids, and we absolutely need to give them glucocorticoids. So all their hormones will be deficient, right? So we're in this emergency situation. So if my thyroid goes down, I'm not going to feel great. If my growth hormone goes down, if my testosterone goes low, but cortisol is the immediate life-saving hormone that we need to give first. Okay. So a lot of times, those of you who work in the ER will often they'll have glucocorticoids for adrenal insufficiency, and they'll catch people with pituitary apoplexy. Okay. So glucocorticoids and monitoring. Obviously, they're going to need surgical decompression and all that, but clearly, what do I want you to know? Yeah, immediate glucocorticoids. Okay. There's our anterior pituitary stuff. I have clinical correlations, but it's you guys good skipping that. I don't. Or do you want me to do it? I'll do it.
No.
But then, okay, so I have one thing. There's our puppies. But don't forget to vote tomorrow. I don't know when. It's my first time voting in person.